So hello and welcome to everyone today. This is the MOASC educational series for oncology billers. My name is Nicole East. I'm the Executive Director of MOASC. Today, this is the second webinar in the series, and we have a fantastic lineup of speakers that will discuss how you can help your accounts receivable team. If at any time you have any questions or comments, please feel free to type them into the chat box or you can unmute your line. I'm pleased to introduce our first speaker, Bobby Buell. She is principal for On Point Oncology. She'll be discussing the billing updates for 2023. So without further delay, I'll turn it over to Bobby.
Good afternoon, everybody. It's nice to be on the same time frame as everybody else, because usually I'm speaking to people on the East Coast at like 6:30 in the morning, and they're all like, oh, why do you look so bleary-eyed? But anyway, it's nice to see you all remotely, and thanks for coming. These are all my disclaimers, but probably the biggest disclaimer that I have today is that the final rule will be out probably next week or the week after, and I still have not received my CPT book. Many people have, but for whatever reason, I ordered it through the AMA, and I have some sort of priority status with them, but I still have not received my code book. So there's some gaps in here that hopefully we will be filling in for you. I will be doing a publicly available webinar in the middle of December on the final rule, because by that time we will have had time to digest it and really understand it. So a lot of stuff we're going to be talking about today is prospective, but we don't know what exactly will be finalized. I will tell you what I think will be finalized, but you never know. One thing that was finalized this week is they did finalize the postponement of the radiation oncology model. CMS postponed it indefinitely yesterday. The other thing that is going on currently is we do have a bill in Congress about prior authorization. I will talk about that. It has not been passed. That is still at the OMB as well. So we are in a transition for a lot of different things right now, but I will tell you what I think will end up happening and some things that won't end up happening possibly. So I am going to talk about the proposed fee schedule rule, the proposed hospital outpatient rule, E&M. One thing that I'm very, very disappointed in is I've just completed 2 major audits, which amounted to almost 500 charts. And I am very disappointed about the status of our clinicians in oncology for E&M. One practice I did was hospital-based, and the other practice I did was office-based, and they were equally clueless about some of the changes in criteria. So I'll be talking about that today. But it is very disappointing, and we will on point. RxVantage will be doing a webinar for physicians on the final 2023 E&M guidelines. Even though most of the E&M from the AMA standpoint has been finalized, it's just the Medicare end of it that hasn't been finalized. And we'll be having a webinar, and it'll be in the evening on the East Coast. It'll probably be late afternoon around here, strictly for clinicians to be reviewing the E&M criteria from 2021 and to 2023. And it'll be open to all clinicians, whether you're an RxVantage member or not. One thing that is really up in the air right now is the status of the public health emergency. This has been actually extended till January 15th. I should change that, till January 15th, 2022. Now, many people think it will be extended past January. I don't think so, because we keep getting all these warnings from the federal government that you should be prepared for the public health emergency to end. And that means, and we'll talk about what that means to us as far as telehealth and things like that, and other waivers are concerned. But I do believe that January 15th may be the end of the public health emergency, and certain things will stay in effect. Due to the Consolidated Appropriations Act of 2022, we will see some things last until 151 days after the public health emergency. So if it ends January 15th, this is about 5 months past that. So it'll be probably the beginning of May that everything will end. We'll talk about what will last for 151 days, what won't last if the COVID emergency is not extended. So we will have a very brief time to get used to it. Now, what will last for 151 days? Medicare will pay for telehealth provided at home. That means that flexibility that you have now to treat patients at home, even if you're not in a rural area, which is the usual Medicare rule for this, you will be able to do this for 5 months. The list of practitioners will stay expanded. Most of these do not apply in oncology. Payment for your telephone calls will continue for 5 months. The delayed 6-month in-person requirement for mental health services will last for 5 months. And that is about it. We'll talk about supervision and some of that, which may even last past the public health emergency, but we'll talk about that later on. The other thing that occurred last year that just for background is for those of you in pharma, there is a drug waste law that if your waste for drugs exceeds 10% over your Medicare sales, that you will have to pay a rebate. That rebate you'll see is part of the proposed rule. Now, again, how it's going to be implemented is still in the proposal stage, but remember that this drug waste thing is the law. And so even if the final rule differs from the proposed rule, this will probably stay in some form or another. So all of these are really important to understanding the proposed fee schedule rule. As you know, and this slide has been around for 100 years. It's been around almost as long as my children. This is the Medicare payment basics. And one thing that you need to know is a lot of particularly our payers here in California, use the Medicare fee schedule, but they don't use the conversion factor. People are very much up in arms right now about the conversion factor, which they very much should be. But the RVUs are what's used by other payers, not the conversion factor. So these are where the proposed regulations are. If you want to go read them all, it's sort of a waste of time right now, considering the finals will be coming out soon, but this is where they are. One thing that makes all of the reductions proposed in the fee schedule even more awful for all of us is that sequestration went in at a full 2% again July 1st. So if you feel like your payments are less from July 1st forward, they actually are, except for your drug payments. Well, yeah, your drug payments too. What am I saying? Your drug payments too. I mean, everything took a hit with sequestration. As we know, sequestration was gone due to COVID. It has come back and it is back in full force. So this is what people are really up in arms about. The Medicare conversion factor has been reduced. Even though it says here that oncology, medical oncology will take a very, hematology oncology will only take a 1% decrease. When we run the numbers, it's quite a bit less. It's about a 4 to 5% decrease across the board for fee schedule items. And remember, our drugs were just cut due to sequestration. So people are really feeling the pain of this. I'm sure when ASCO comes on, they will tell you that ASCO has certainly pushed back against this. COA has pushed back against this. And most special MGMA has pushed back on it. Most specialties have, because nobody can really afford to take this hit right now, particularly with sequestration coming back and inflation in full force. So what's going to happen in terms of the proposed rule as far as telehealth is concerned? Well, telehealth has three different categories. One is sort of the permanent list that can be done by telehealth under the old rules. And we all remember the old rules of telehealth. The patient must be in a rural area. They may not be at home. They must be in an institution. You must have valid two-way communications, not like FaceTime or something like that. It must be full two-way communications, and you may only do category 1 and category 2. Category 3 is a new category in 2020 that are temporary, and they will remain in effect until the end of the calendar year in which COVID-19 public health crisis ends. And because the public health crisis has been extended to January of 2023, that will be 2023. So there are two types of, as we've sort of reviewed so far, there are two types of temporary telehealth services. Those that will expire 151 days after the expiration of the public health emergency, and those that are category 3 that may become permanent or expire at the end of 2023. These are additions to the category 1. These are prolonged services codes. There are 3 of them that are proposed, whereas CPT has only proposed 1. Which is really bad. This is in addition to G2212. And these are 3 different ones that match to various out-of-office services for 2023. Why Medicare had to have 3, I don't know, but they did. So the category 3 list contains services that are likely to have a clinical benefit. These are the ones that will end at the end of 2023. There are 54 codes that are proposed for this list. These services fall into 9 categories. Therapy like occupational and physical therapy, electronic analysis of implanted neurostimulator, adaptive behavior and behavior identification assessment, behavioral health, ophthalmological services, cognition, ventilator management, speech therapy, and audiologic. And I don't have the link in here, but we will see what happens with category 3. These actually may be extended to 2024. So what expires 151 days? We actually have audio-only telehealth services. CMS proposes that providers will add modifier 93, which indicates an audio-only service effective January 1st, 2023. Now, one thing that sort of bugs me, and this is something I responded very heavily to for the proposed regs, is CMS adding all these different coding regulations over and above what CPT does. As many of you may not remember, but I do remember because I'm old, is that when HIPAA was passed, we were supposed to have 3 coding systems, essentially. ICD-9, and which became ICD-10, CPT, and HCPCS. CMS has, has added so many things to CPT that it makes your head spin after a while. And you'll see some more examples of this as we go on, but it's very distracting to have 2 different coding systems like CMS has. So CMS is proposing that providers add 93. Whether this will actually happen or not, we will see in the final rule. So that's something to mark. They will postpone the effective date of the telemental health services, where you have to have seen the patient within 6 months before you start this telehealth, and every 6 months, at least once thereafter. Now, this is something I responded to. virtual supervision, because this would literally change oncology in some very positive ways. If you could supervise patients, supervise providers incident to a physician service virtually. And this is true now, but it will not be true once the public health emergency ends. So, and this is not in the 151 days. And CMS proposed to make this permanent last year, but then they backed off in the final rule, basically saying that people would supervise more than one office at a time. So I responded, well, just restrict people from only supervising one office at a time. And providers would have to, it would be part of the incident to rules. And so we hope that this comes back. I'm dubious because CMS came out very negative against this, but it would be really nice for oncology if virtual supervision would stay around. So obviously there are some E&M changes, and we will review these a little bit later. And again, we'll have several other workshops before the end of the year. So 2022, we've had a final rule for split visits. As we know, split visits only apply to out-of-office visits. That includes for those of you who belong to a hospital and you are billing for hospital outpatient, place of service 22, this does apply to you. It does not apply to you, but those of you in office-based oncology. Okay, the split visit rule. Incident to is the same as it ever was. It has not changed. We would hope that it might change for virtual supervision, but that's about it. Also, advanced providers can bill under their own number. Physician's assistants can bill under their own number as of this year, and nurse practitioners and PAs can bill under their own number. But these split visits are anytime you're not in the office and governed by either billing under your own number or the incident to provisions. So CMS says whose number and name should this be billed under? And CMS says only the physician or nurse practitioner or PA who performs a substantive portion of the split visit would bill for the visit. Okay, so that means you have to do one whole portion of the three categories of which currently for the next couple of months, history, physical, or medical decision making, you must do that portion or do more than 50% of the time for that visit, and you must record the times, the amount that the provider spent. And that person, whoever is billing for it, must sign and date the note. So, and this will carry on. As proposed into 2023 as well. Just to give physicians a transition year. Now, again, that's proposed, but I think that will stick. So what should you do? And they clarified that they're going to continue to do this history, physical, or medical decision making. You must do every single portion of it. It cannot be split. And that person would actually bill for that visit. Or again, you can use time. CMS will have 3 separate codes, as we said, for prolonged services. These will be added to the highest level of prolonged services for these different categories. And we'll talk more about this later. And so these are the various time thresholds for E&M. And again, this is just for CMS. CPT has totally different rules. Now, what makes this so completely confusing and crazy? What makes it so completely confusing and crazy is, as you might remember, CMS proposed a G2212 for your prolonged services in the office. And CMS proposed 99417, which I always call 96417 because I have infusions on the brain, but it is 99417. And, so which payers are using which code? Well, it turns out that United Healthcare uses G212. So what private payers are going to use these codes just to make life ever more confusing in terms of office billing? That's a very good question. Now, drug wastage is going to be implemented. And CMS asserts that the JW modifier is not used correctly in all cases. So again, just to add to the confusion, they are proposing a new JZ modifier when you don't waste anything. Why we have to have a JZ modifier is a total mystery to me. Because if you're only billing one line, obviously you're attesting to the fact that there's no waste, right? I mean, so what do we need another modifier for? That is an extremely good question, and I don't know the answer for it, but I always say the JZ modifier will be followed by the Beyonce modifier. It's an old joke, but it will make you remember the JZ modifier. So how is drug wastage, for those of you in pharma, going to be implemented? First of all, for those of you in the office, CMS basically says that they will be auditing people with JW modifier, and the RACs have actually started doing that in some parts of the country. So if they see so much waste, like for example, we all know there are a lot of drug shortages out there. If a specific distributor runs out of the smallest version of that particular drug and you have to buy a bigger version, please save all your documentation because if the waste is excessive, they're going to come in and look at you for sure. Now, some drugs are going to be excluded from this. Drugs that are bundled drugs, radiopharmaceuticals, imaging agents, drugs that require filtration, drugs for which payment under Medicare Part B has been made fewer than 18 months. And that 18-month period runs from the date of the first sale, as reported to CMS, to the first day of the 6th calendar quarter thereafter. This 18-month exclusion only applies once. If generic versions come out, that J code, it's not going to happen again. And this period will start when the law was passed, which was around the 15th of November in 2021. And again, it's the 10% over and above your sales. So your fine or your rebate is based on that 10%, not your total sales. So the report of what is owed will be delivered annually, no later than October 1st. So obviously, if this goes into effect January 1st, there will be no fines January 1st. And the fines in the first year will only be for quarter one. In the second year, it will be for 4 quarters. And these are some of the drugs that were cited by CMS as having excessive waste. You can see that a lot of these are cancer drugs, but this is 2020 data. So we'll see if this data holds out to 2022. The other thing is Medicare, if patients have a colonoscopy and they have an additional procedure with it, say they take out a biopsy or they take out a polyp or both, Medicare will start phasing down the co-payments for patients. Patients already don't have to pay a copay for screening colonoscopy, but they will be phasing down the additional services with screening colonoscopy until 2030. So you can see that in 2022, nothing much is happening. But in 2023, CMS will start paying 85% of screening colonoscopy. And they will also expand Medicare coverage for some screening tests by reducing the minimum age to 45 years. Of course, there's not many 45-year-old people in Medicare, but there are a few. And again, they will include all that. There will be, and this does apply to some oncology practices as part of implementing a behavioral health strategy. The 2023 Medicare Physician Fee Schedule proposed rule creates the new G code and we'll see what that is, to allow clinical psychologists and clinical social workers to bill for general behavioral health integration. Now, clinical social workers can currently bill for care management if they're coordinating patients' care, like getting them on Medicaid, well, Medi-Cal in this state, helping get placement for patients that need to be in a nursing home or whatever. But this is for behavioral health integration, patients that have depression and things like that. If your social workers are doing this, they will be allowed to bill for this new G code next year. It also amends the general supervision requirement under CMS's Incident 2 services. So it'll be general supervision if the patient wants to call the practitioner off or the social worker off hours. They don't need to be Incident 2 all the time. And, they will be furnished by clinical staff under the general supervision. But when the physician's in the office, it's Incident 2. They're also, and we see more and more oncologists getting involved in pain management. There will be a new pain management code for a monthly pain management treatment for assessment and monitoring, administration of validated pain rating scales, and I see these all the time in oncology records, overall treatment management, coordination of any necessary behavioral health treatment, medication management, pain and health literacy counseling, any necessary chronic pain related crisis care, and ongoing coordination between relevant practitioners furnishing care. And this will be $80 approximately for each 15-minute increment. So this will pay really well. And I sometimes feel like I'm wasting my breath telling people to bill these additional services for Medicare. But this is something that, and these are not the codes, obviously, there'll be real codes coming out. But these are real services that you can get paid for. And I do see documentation of this. The only thing that people will need to remember is you need to document that you spent 15 minutes. And generally people spend like 5 minutes, maybe each time the patient comes in. So, asking this question, and maybe you want to have a more formal questionnaire for pain management when the patient comes in, so that people can review it offline and get their 15 minutes in. Vaccine pricing has gone up mainly because of COVID. CMS will now pay $30 a dose for administration of vaccine, which is more than a 96372, I believe. So, and these will have geographic adjustments, which they didn't in the past. This is something that's been, this is like the imaging thing. This has been on the books a long time, but it's been put off for years. It was supposed to be January 1st was the compliance date with this. CMS extended the compliance date to January 1st, but they really put it off. In 2023, warning letters will be sent. No monetary penalties will be levied for not e-prescribing controlled substances. They will just warn you. CMS also says that for providers to be considered compliant, 70% of your controlled substances prescriptions must be done electronically. Now, one of the big exceptions to this, and this applies to a lot of you, is it's for prescriptions issued where the prescriber and the dispensing pharmacy are the same entity. So if you're dispensing these drugs to patients and you're prescribing, this law does not apply to you at all, and you don't need to worry about it. And there are other exceptions to it. And of course, appropriate use, the penalties have been postponed indefinitely. I have heard that oncology practices are doing appropriate use criteria. I don't really know why, because it's been on the books since 2014. I don't know if this will ever happen, but it is complicated coding and billing. So if you have imaging in your practice, or if you're in a hospital outpatient that has it, it could happen at some point, but I just don't see it next year. Also, MIPS will continue next year. It's going to be a little different because they have these things called MVP, and that's not the most valuable payer. It's the MIPS value pathways. And these are sort of like the old measures groups, where they want your reporting in all of your MIPS different quartiles to be related and to be easier for reporting. And also, eventually, they probably will want you to take risks for this, just like they do for the managing the EOM module, and before that for the OCM module. These are trying to be a little bit consistent, and we do have one in oncology that I'll talk about in a minute. MIPS 2023 will be cost 30%, which is a lot. Quality 30%, improvement activities 15%, and promoting interoperability, those are the same as they ever were. And these are the MVPs for 2023. Originally, they were just anesthesia, chronic disease management, emergency medicine, heart disease, lower extremity joint repair, rheumatology, and stroke care. But you can see they have one for advancing cancer care. And the measures are posted on the ASCO website. And they don't look particularly consistent to me, but that's what they're supposed to be. And they did add some other ones too, for those of you in multi-specialty practices, particularly promoting wellness may be a good one for you. So how are the MVPs scored? First and foremost, you must register to be in MVPs as an individual, a group, or a subgroup next year. Quality reporting, I think they might get rid of that, by the way. MVPs will select 4 quality measures. One must be an outcome measure, which is very similar to what you have now in MIPS. This can include an outcome measure calculated by CMS through administrative claims, if available, in the MVP. Improvement activities. MVP participants will select 2 medium-weighted improvement activities, or 1 highly weighted improvement activities, or participation in a patient-centered medical home. And then there's the cost performance category, and there are population health measures in that. You must select 1 population health measure to be calculated on, and there will be 2. These are the 2 ones for 2023, at least as proposed. And then promoting interoperability, MVP participants will report on the same measures required under traditional MIPS. And this is the ASCO website, where you can go see an example of an MVP and how you would deal with that. So going back to traditional MIPS, you must report at least 6 measures, including at least 1 outcome measure. Data completeness standard will be 75% for 2023, up from 70% of your patients. And improvement activities and promoting interoperability will be a 90-day attestation, exactly like they are now. But here's something kind of tricky. If you're in an APM, which no oncology practice probably is, because there's no APM for us this year, there's really no bonus for it. And then next year, there will only be a small 0.75% conversion factor update available in payment years 2026 onward. So that would be your reward for being in an APM. And a lot of people believe that for all the trouble that you need to get in an APM, this is really not fair payment. So we'll see what CMS does about this in the final rule, because they're trying to encourage people to get into APMs. But again, this does nothing to really help people. For those of you in medical shared savings programs, CMS does propose several changes to them, including longer guide paths to downside risk, So they will, they will do that. Also, many of these ACOs were starting to go out of business. CMS will offer new ACOs the opportunity to receive advanced shared savings payments of $250,000 to fund infrastructure development. I'd rather have them be funding the physician conversion factor, but they didn't really ask me before they did this. And then they proposed several changes to reduce the administrative burden of these shared savings programs. Now, the outpatient proposed rule really doesn't have as much stuff in it. There's somebody waiting to get in, by the way, folks. Medicare hospital outpatient proposed rule it does not have as many changes this year as does the physician rule, but some things in the physician rule like the E&M and the waste and things like that really also apply in the hospital outpatient setting. Medicare will pay 2.7% more, and that's not all, as you'll see in a minute, for outpatient and ambulatory surgery center services. That's a big increase, particularly compared to the big decrease we're getting on the physician side. They're also proposing an increase in the drug bundling next year to $135 or less. And this, of course, is calculated by CMS. It's not calculated by the drug companies. They will pay non-pass-through drugs and biosimilars acquired under the 340B program at ASP minus 22.5%. That's what they say, but see the next page. CMS intends to withdraw the payment cuts in 2023. But 2 weeks ago, a judge ordered CMS to adjust drug allowables now. So CMS is starting to change prices as fast as they can this week. Well, they started last week, but it's really going to be implemented this week so that most drugs will go back to ASP plus 6% before the end of the year. I don't know exactly how this is being rolled out, but it is being rolled out now. Because a judge basically said, you lost this lawsuit, you better get yourself together and do this. Now, the big unknown in this entire thing is what's going to happen to all those reductions that occurred between 2018 and 2022. In some ways, hospitals should be careful what they wish for, because if Medicare has to pay this back in full, which is dubious because they're trying to take surveys to see that they don't have to, but let's say they do, where is that money going to come from? And if it comes out of the hospital reimbursement, everything across the board, and I mean, I'm talking of surgical procedures, eye procedures, physical therapy, inpatient procedure, everything will have to be reduced for budget neutrality. So this is a real question as to how exactly this is going to be done. And nobody has come up with a solution as of yet. But certainly right now, things are going back to ASP plus 6. Also, the behavior telehealth services, this is very similar to what's in the physician proposal. Also, there's a potential pay increase to pay hospitals for the extra cost of buying domestically produced N95 respirators. Payments would be bi-weekly, that was sort of a typo, and reconciled in cost reports. CMS proposes also to clarify that non-physician practitioners, nurse practitioners, clinical nurse specialists, physician's assistants, certified registered nurse anesthetists, and certified nurse midwives can provide general, direct, and personal supervision of outpatient diagnostic services to the extent that they are offered to do so, that they are authorized to do so under their licensure. The agency also proposes to remove 10 procedures from the inpatient only list. Those will go to outpatient. And CMS, as you know, for the last several years, CMS has had a few, not very many, but a few procedures under prior authorization. We hope that doesn't spread any further. Facet joint injections and nerve destructions will be in prior authorization starting March 2023 if this proposal goes through. So E&M changes, these are final, and there are a lot of changes, but they do not apply to office-based services or to hospital outpatient. These are out-of-office changes that we all expected actually for this year, and these are final. The Medicare G prolonged services, those are proposed, but everything else is sort of final. So in the introductory guidelines to CPT are revised related to hospital inpatient and observation care services, consultation codes, emergency department services, nursing facility services, not all of them, and home or residence services, these codes. Now, probably the biggest change for all of you is that hospital inpatient and observation care have been mashed up into one set of codes. Okay, so that's what's happening there. All of these now have, and you'll see, have a descriptor that basically says that time and medical decision-making are now the criteria for these codes. History and physical and medical decision-making, well, not medical decision-making, but history and physical are really only as clinically opportune for those patients. ED department codes do not have medical decision-making. They are strictly based on time. So deletions, observation services, consultations for those payers that still pay them, level 1 is gone. Nursing facility services, 99318, domiciliary rest home or custodial care, all of these codes. Deletion of home or residence service, 99343, and deletion of the all prolonged services codes, 99354, 355, 356, and 357, in favor of the new codes that will come out. So for those of you who have these on super bills or in your charge description master or wherever it resides, these are all going away come January 1st, and this is final. So, you know, if we weren't confused enough about what is a new patient, CPT has sought to redefine this. A new patient is one who has not received any professional services from a physician or other qualified healthcare professional, or another physician or another qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. When advanced practitioners are working with physicians, they are considered as working in the exact same specialty and subspecialty as a physician. Because people have always asked me, are nurse practitioners and PAs considered the same specialty as a physician? And I would go, well, under what their provider designation is, no. But if they're working, as a physician, under their supervision, I always thought they were considered the same specialty. Subspecialty is a new one, though, on me. Initial versus subsequent service. Now, as you know, in the hospital admissions versus when you visit the patient later on, there are initial versus subsequent service. Now, this is definitely a change because, and I do not know, and this is something that I question, when you're doing a consultation on a patient, it's an initial service, but this contradicts this. But CPT still has consults, whereas Medicare doesn't, and Medicare did not clarify this. So this is something we are looking for them to clarify. An initial service is when the patient has not received any professional services from the physician or other qualified healthcare professional, or another physician or qualified healthcare professional of the exact same specialty or subspecialty who belongs to the same group practice during an inpatient observation or nursing facility stay. So that doesn't really contradict the consultation, but I would definitely like Medicare to clarify that. Because I mean, obviously, if you're asked in as a consultant, you're probably a different specialty, but I'd still like this a little more clear. But that is a definite change from what it was before. So again, this is something to put on in your bag of tricks for next year. Again, this is very similar to what the outpatient requirements are. Tests that do not require separate interpretation and are analyzed as part of MDM do not count as an independent interpretation, but may be counted as ordered or reviewed for selecting an MDM level. And this is just a clarification from 2021 guidelines. It's really not very different. The new AMA document includes, and the book includes revisions to the MDM chart. Under low complexity of problems addressed, one acute uncomplicated illness or injury requiring hospital inpatient or observation level of care. If it's an acute uncomplicated illness, I'm wondering why medically necessary for it to go to the hospital, but this is just a new definition. In addition, there are 2 revisions to high risk of morbidity or mortality. Parenteral controlled substances is listed, and decision regarding hospitalization will be revised to decision regarding hospitalization or escalation of hospital level care. We will have a new cheat sheet for hospital services as soon as Medicare finalizes whatever they're going to do here. Problems addressed. For hospital inpatient and observation care, the problem addressed is a problem status on the date of the encounter, which may be significantly different than on admission. It is the problem being managed or co-managed by the physician or other qualified healthcare professionals that are seeing the patient. You know, and if somebody else is managing that problem, then you don't, it doesn't become part of your medical decision-making for that date in the hospital. Definition of an independent historian. This hasn't changed a lot, except for it does not include translation services. That was a question a lot of people had, but it must be somebody it must be a person too. An independent historian is not a note, it is a human being. And so these are what these look like. Now notice, as opposed to the outpatient codes, these all have an exact time, okay? Whereas the outpatient codes have a range. So this is what the hospital and now the observation mashup codes are, and what kind of decision-making they have and time. But these codes are still around: inpatient or observation care, admission and discharge on the same day. And hospital discharge services, these are the same as they ever were. Emergency department, notice time is not a factor in the emergency department. And nursing facility. And then these are the prolonged services. Now, I don't have my CPT book, but some of you may. This is actually a code. So there's 2 prolonged services codes for CPT. There will be 4 for Medicare, which is totally crazy. But these are the rules around prolonged services. Just like in the hospital outpatient side, these must be at the highest level. So if you're billing prolonged services, let's say with a follow-up hospital visit, you would have to be at 99233 plus your 993XO, and that is a code. That is officially a code. It'll have a number in there, but that's how these prolonged services work. They must be attached to the very highest level of service. You probably all are had a lot of information about the enhancing oncology model. So I'm not going too crazy, because you must have signed up by 10/10/22. Is it beneficial for your practice to participate? Well, you probably already made that decision. Again, the monthly fee has gone to $70. per month per patient. And chronic care management done by your staff for 20 minutes is $64 a month. As an economic decision, I don't know. The cancers are limited, very much fewer cancers than were in the original program. So you will have less patients for the most part, depending on your patient mix in your practice. And there are more participant costs added, but people do want to be part of the future, and the EOM and things like that probably are part of the future. But economically, I don't know how much sense I think this makes. Obviously, you must take risk, and there are two different risk arrangements that you can participate in. Some of them have bigger upside risk, but more downside risk. It's really up to you as to which one you would want to participate in. And then this is just sort of a comparison of the OCM and the EOM, and what they are like. Now, one of the big changes that we had is the Inflation Reduction Act. And it really doesn't affect practice billing as much as it affects drug companies, but there are a few things that affect you out there. First of all, the beneficiaries can still enroll under the ARPA tax credits for the silver plan. And they're extending them beyond the 400% federal poverty level by capping beneficiary premiums at no more than 8.5% of an individual's income for a silver plan. And that means more of your patients can enroll in Obamacare. There will be Medicare drug pricing negotiations, not for Part B for a while. Biologics, for which at least 11 years have elapsed, are eligible, but small biotech drugs, orphan drugs, low-spend Medicare drugs, and plasma-derived products are excluded from price negotiation. And drugs subject to this in 2026, it will be Part D drugs. 2027, it will be Part D drugs, 15 drugs as opposed to 10 drugs the first year. 2028, both Part B and D drugs will be 15 drugs combined, and 2029 will be 20 drugs. Now, remember, we are going to have an election in 2024. And if the administration turns over, all of this could be evaporated. But this is what it is today. Once the negotiated price is set, and this is the whole process, which you can read, but you can't delay negotiations for more than 2 years unless there's a biosimilar coming out within that time. It also includes enforcement provisions, as does the waste law, that you can be fined for not negotiating. And then the inflation rebates. Inflation rebates on Part D drugs started October 1st, and they will start on Part B drugs in January of 2023, which isn't that far away. A manufacturer that does not pay the rebate on the inflation would be subject to civil money penalties equal to at least 125% of the rebate amount. And then some good things are there will be an out-of-pocket cap for Part D. Starting effectively, they will eliminate the 5% cost sharing and caps their total out-of-pocket in Part D effective the following year in $2,000 to $2,000, which is fabulous for patients. Payments for biosimilars went up, if in case you didn't notice. On October 1st, they went to ASP +8. This is temporary. It will go for a couple of years. For new biosimilars furnished on or after July 1st, the initial payment period rate will be the lesser of the biosimilars wholesale acquisition cost plus 3% or 106% of the reference products ASP. So this won't last forever, but it is on now. There'll be a maximum monthly cap on cost sharing payment under prescription drug plans. There'll be a cap on premiums starting in 2029 of 6%, and there'll be better low income subsidy eligibility for your patients under Part D starting January 1st of 2024. And this is sort of the timeline on everything I was just talking about in terms of patient rates and drug negotiation. Whoops. And one last item, so I can have a few minutes for answering questions. One last item is there is a bill in Congress. And this bipartisan legislation will establish an electronic prior authorization process and more scrutiny for MA, Medicare Advantage plans and Medicaid plans to delay your prior authorization. It has passed the House. It is in the Office of Management Budget, and we certainly hope that it passes or is attached to one of the bills towards the end of the year. This is something that ASCO is very much, you may have taken the ASCO survey. We've done endless surveys on prior authorization. It is the biggest problem in healthcare billing that there is. The AMA has done extensive study on this as well, and they have actually proven that it is harmful to patients. So we hope and pray that this legislation passes. And a word to the wise, please make sure your physicians are educated on E&M before the beginning of the year. We're doing our part to make sure that happens. And Nicole will be getting back to you with the dates that where we're doing public presentations on evaluation and management. But make sure your clinicians are clear about this, because in the charts I've seen, they're all still doing 95 and 97 criteria, even for time. And that is not good. So I hope I can answer a few questions, and I thank MOASC for having me today, and thank all of you for attending. And if you don't subscribe to our newsletter, that's where you can subscribe. And that's Carmel Beach for those of you Californians out there.
Thank you so much for that information, Bobby. So if anyone has any questions, go ahead and feel free to type it into the chat or unmute your line.
And yeah, you can certainly also email me privately. MOASC members email me privately all the time, as early as yesterday. So if you are too embarrassed to ask a question, you can email me at bbuell@onpointoncology.com or bobbybuell1@yahoo.com. This is a very inhibited group, I might add.
I wonder if they're feeling a little overwhelmed.
Well, it is a lot of information, and the only thing we have to do is watch and see what is finalized in all this. But the E&M is definitely finalized. That's why I encourage all of you to make sure that your providers are educated.
All right, well, last chance to ask Bobby a question. All right, hearing none. Okay, so we have, wow, you actually finished about 20 minutes early.
I did. Oh, I thought I had an hour. Well, that's very nice for whoever's is there's somebody on next, because I can certainly do something else.
They are not on the line yet. So
okay.
If you have anything to add, I mean, we certainly have time.
Would you guys like to see a presentation of 2021 and to 2023 E&M? Because I can do the first part of it. The second part of it I've already done.
Yes, please.
Okay. I got to get it out of my box here. Okay.
Well, and since this is the one for the clinicians, correct?
Yeah, this is the one I do for clinicians. Wait, let me just see if I can get it.
Perfect. Since we're recording this, we can share it with them as well.
Okay, what if I can find it? I have too much E&M stuff in here. Okay, I can do this one. Yes, this one I have other topics in this, so I won't send you the whole thing because it's got telehealth and stuff in it, which I've already done. So I don't worry if I'll give you another one without all the telehealth stuff because I have that in this. Now, if I can just. Okay, so this is E&M from the very beginning, and the 2023 part we've already done. So the E&M changes in the outpatient were, as you know, January 1st of 2021. But if I look at a lot of physician documentation these days, they're still saying, oh, I spent more than 50% of the time counseling the patient. And sometimes that's not helpful because their documentation is really good enough for them to be in a higher level of service. Sometimes they do these boilerplate cut and paste kind of notes with a history and physical. Sometimes the history and physical isn't really necessary. It just, they're still not aware of how this has changed.
Hey, Bobby.
So, yes.
I apologize for interrupting. We have a question that popped up in the chat. Can you answer that before moving on?
Sure.
Okay, so the question is regarding pushback with incident 2 for billing for PAs and NPs with commercial payers.
Well, incident 2 is really only a Medicare machination. You really can't hold private payers to it. I know practices that have incorporated that they want the same kind of guidelines that Medicare has for nurse practitioners and PAs, but some of them will only allow them to bill independently. So, it is something to look at in your contracts with these folks as well. I mean, I will tell you, and I hate to be a pessimist, but I have, incident 2 is a very good thing for practices in many ways. It allows your nurse practitioners and PAs to bill under the physician number, which is better financially. It also allows, the only way you can bill for Part B drugs is under the physician's number. And so that keeps specialty pharmacies and infusion centers and all these things out of our faces on the physician side, but it doesn't, on the Medicare side, but it does not do that in commercial side. So that's why I would say if you have any negotiating leverage, which sometimes you don't with these private payers, I would ask that people could bill incident 2, but certainly commercial payers are not subject to Medicare rules unless they're Medicare Advantage. Then if you're billing under Medicare Advantage, they should be subject to the incident 2 rules. Does that answer your question out there? Okay. Going on with this. So there's many things that were new in 2021, but the biggest things were our physicians using time or medical decision making. One thing that I certainly recommend that you say to your physicians is they should document in each note what criteria they're using, because I'm looking at notes where physicians are documenting time and medical decision making. But if I'm a Medicare auditor, I'm going to look at you and say I'm going to take the lesser. So let's say you're billing a 99214 and your decision making is really 99215 because the patient is, has a bunch of problems. They're going to chemo, you made a decision to go to chemo, which is a high risk procedure according to medical decision making. And yet you're saying I spent 15 minutes with the patient. Well, you're going to get downcoded. So, to me, if you're using medical decision making, you should have a little box in the note that says medical decision making. I address these problems. I reviewed these tests with the patient and family. I am changing their medications, which is prescription drug management, or I am changing their chemo, or I'm reviewing their chemo. Whatever, that would put you possibly to 215. But, if you're sitting there saying I had 15 minutes, that's not going to do it. So you really should make a decision for each visit, exactly what you're doing. These are, I'm sure you know about all these things, but 1995 and 1997 criteria are gone. Physicians should say goodbye to it, and they should also say goodbye to all the cutting and pasting that goes with it. There was just a study done by the American Health Information Management Association, sometimes known as the HEMA, where they showed that 51% of charts have cutting and pasting in them. The cutting and pasting is not necessary under this new criteria, so knock it off. That's all I have to say. Time for coding purposes is not just counseling and coordination of care anymore. It is actual specific activities by the physician or other billing provider on the date of the encounter. It is not incident to, it does not include staff time. It is the time that the billing provider spends on the date of the encounter. So bringing in these histories of the patient having an appendix in 1950 really doesn't cut it. And again, it's all this cutting and pasting that really makes no sense, because really what counts in the new definition of E&M is what happens the date of the encounter, either before or after. Split visits, and this is in the office, really is when you're using time as a criteria. And you have two different providers providing a service, where the nurse practitioner or PA does a brief history and a relevant physical, and then the physician comes in and does the medical decision making. You can base that on decision making, but you can also base it on who spent what time. The only thing is, if they're doubling up on time, only you can only bill that time once. You can't bill it for two providers at the same time. You can only bill for that time once. And this was always the most confusing part. If you're doing unique tests for which there is not a separate code, when you're billing for codes, it's really the CPT code. So if you're billing for a chem panel, there's only one code for that. If you're billing a CBC, there's only one code for that. And they don't have interpretation factors. And it doesn't matter if you're billing for it or not, but if you order or interpret the test on the date of the encounter, and you can't bill it twice. So I always say to people, bill them when you analyze them, unless you're ordering a series. If you're ordering a series, bill for the order, if you say CBC each time the patient comes in, and then you can bill for the interpretation thereafter. So those are unique tests. They must have their own CPT code, and you may bill for it. You may consider it as part of MDM, even if you're billing for it, unless it has a separate CPT interpretation code. If you're talking to an external physician, that's somebody outside your practice, or somebody who's in a different specialty or subspecialty. So if you're a medical oncologist and you're talking to a radiation oncologist to get an interpretation, you can go ahead and bill, say that's an independent interpretation. Or if they're asking for your interpretation, if it's a radiation physician. An appropriate source is when you're discussing this with somebody external, like a social worker, a case manager, a teacher, a parole officer. It does not include discussion with family or informal caregivers, but that can count as time. So if we're talking about medical decision making, it really never changed very much. It went from the number of diagnoses that you're considering today, the amount of complexity of data that you have to review, and the risk of complications, morbidity and mortality in today's visit. None of this has to do with whether somebody is going to die in the long term from cancer or whether they're at risk in the long term. It's the risk of your decisions today. What are you doing? What are you looking at? What data are you reviewing today? And what problems are you addressing today? Again, this criteria is all about what's going on today. And it's very important that the decision-making be broken out in some way or another, because if it's scattered throughout the note, it's a real hassle for auditors, take my word for it. So if there's 3 elements of medical decision-making with only 2 out of 3 counting. So the number of complexity you address today, the amount and complexity of data to be reviewed or analyzed, the risks of complications or comorbidity or morbidity associated with the patient's problems, their diagnostic procedures, or their prospective treatment options. And this is our RxVantage medical decision making cheat sheet that we put out 2 years ago. Gosh, and we'll be putting out one like this for out of office procedures too. One thing I want to mention about out of office procedures while I'm thinking about it having nothing to do with the sheet is please make sure you do an audit to make sure that the date that you're billing for hospital visits matches the date of the dictation. One of the audits I did, there were a tremendous number of charts where the dates don't match, and an auditor would deny all those cases. So you can see here, particularly in the amount of data or complexity of data, things change as to how many tests there are, the complexity of tests, whether you had an independent interpretation, which is a category 2, or if you discussed this interpretation with another physician, that puts you into a higher level of medical decision-making. Also, the number of problems and the types of problems you're considering today, and then, of course, the risk. And of course, drug therapy requiring intensive monitoring, that goes down. Prescription drug management, though, is a lot simpler than people think it is for moderate risk. Prescription drug management is even if you're reviewing the patient's prescriptions before you see patients, which many oncologists do, or if you're reviewing the patient's meds with the patient, or if you're changing their meds, or if you're adding to their meds. Any of that is prescription drug management. So we talked about complications and complexity of problems. Obviously, acute problems are more than chronic problems, but if a patient has several chronic diseases, those add up. And this is the chart for all of those. And then criteria of 2, category 1 is just review of prior notes, review of results of a test, ordering of tests, but you can only count either or, review or ordering, an assessment requiring an independent historian, and as we said, that can't be a translator earlier, an independent interpretation of tests, and discussion of tests or interpretation with an external person, an external physician or NPP, or patient's teacher, their parole officer, their caseworker, whatever. And again, you can't report anything twice. So if you're reporting at the time of ordering, you can't report it in medical decision-making at the time that you analyze it. And then these are, how you get from one category to another in terms of tests reviewed or ordered. And then criteria 3 is the risk. And again, it's the risk of your decision today. So you can see here, prescription drug management is in a level 4. Drug therapy requiring intensive monitoring for toxicity is in a level 5. And remember that for medical decision-making, the criteria is only good 2 out of 3. And then this is just the full example of monitoring for toxicity, but we know for oncology drugs, most of them do have to be monitored for toxicity. Now, time is really the time of the date of service. And time is really defined in the codes. And this is what the time has to be: preparing to see the patient, obtaining and reviewing a separately obtained history, performing a medically appropriate examination or evaluation, counseling or educating the patient or family caregiver, ordering medications or tests, referring and communicating with other health professionals, documenting clinical information in the health record. Now, doctors have been asking for that for years, but I have not seen one doctor say, I spent 20 minutes documenting this in the chart because Epic or Onco EMR or whatever stinks, which is what they're all thinking. So, remember, they can actually bill for that. Independent interpreting results and care coordination if you're not reporting it separately. And so these are all things that you cannot bill separately. Chronic care management, if you're billing it separately, which some oncologists actually are these days, I'm proud to say. Performing tests and procedures billed separately, and preparing staff or for drug administration, which is billed separately. And preparing staff means just giving the orders, reviewing the tests, and sending the staff on their way. So these are the time increments in E&M. And then there's a prolonged services code, which I always like to say is 96417. It's actually 99417. And it's only attached to level 5, as we said before. And these are the time thresholds by the AMA definition. Medicare is 15 minutes later. And that's why they have their own code, G2212. And this is the descriptor of that code. And it can only be attached to level 5 codes. For Medicare next year, they are proposing that you can't use non-face-to-face services for E&M bill the days before and the day after E&M. We'll see if that goes through. And then this is Medicare's G212 thresholds. And this is all of it put together. Which we also have on a cheat sheet. So that's a little bitty review of what we have now. We've gone through this E&M 2022, but I did want to do a little review for you and for any physicians and nurse practitioners and PAs listening in, because I really think E&M 2021 has not quite permeated all the membranes these days. And it's nice to have a little review of it just to make sure you're all doing what you're supposed to be doing in terms of documenting in your charts. So I hope that was a little bit helpful. Are we still on? Hello?
We are. So does anybody have any questions on the information that Bobby just presented?
They're stunned out there.
I think so. All right. Well, hearing none, then we will go ahead and take a brief break, and we will return at 1:55 for our next session. Thank you so much, Bobby. Appreciate it.
Thank you.
Bobby.
Oh.
Yeah.
Go ahead.
Is somebody out there?
I just said thank you. Thanks, Bobby, and nice to see you.
Nice to see you. Take care.
Yep.
Can I share my screen, Nicole?
Absolutely. Just 1 second.
Oh.
There you go. All right. Well, she's bringing up her screen. I'll do a brief introduction. So our next speaker is Allison Hirschhorn. She is the Associate Director.
The portal showed it as secondary. Yeah.
Hang on 1 second.
Called Medicare, and they said it was primary.
Okay, she muted her line. Again, that's Allison Hirschhorn. She is the Associate Director of ASCO, and she will be discussing the social determinants of health and how to bill Z codes. Well, Allison, I'll turn it over to you.
Yeah, thank you so much for having me here today. Really excited to be giving this presentation because it's actually one of my favorite topics. I'm very enthusiastic about it. As Nicole said, I'm Allison Hirschhorn. I'm the Associate Director of Coverage and Reimbursement here in ASCO's Care Delivery Department. And today I'm going to be speaking to you about social determinants of health and the ICD-10 CMZ codes. And I'm going to apologize preliminarily because I'm recovering from a bit of bronchitis, so maybe coughing every once in a while, so just bear with me. Today, we're specifically going to be focusing on data and utilization, care delivery regarding social determinants of health, how to address social determinants of health in terms of practice administration, the ICD-10 CMZ codes themselves, and how to connect those Z codes with CPT codes. So first, what are social determinants of health? They are conditions of an individual's living, learning, and working environments that affect one's health risks and outcomes. They're recognized as important predictors in clinical care, and positive conditions are associated with improved patient outcomes and also reduced costs. There are a certain section of ICD-10 CMZ codes that are directly correspond to social determinants of health, and that is persons with potential health hazards relating to socioeconomic and psychosocial circumstances. And by identifying patients with social determinants of health, reporting their corresponding Z code, it will hopefully lead to improved quality, care coordination, and also experience of care. There are a lot of challenges with social determinants of health data collection. And challenges currently include a lack of a standard EHR-based screening tool, a simultaneous lack of and multiplicity of codes, which I will demonstrate later, and just a general lack of awareness among providers and medical coders about the existence of the codes and also how to report them. Some potential solutions may include reducing reliance on clinicians to capture social determinants of health, filling gaps in codes where needed and streamlining in certain areas, and then also improving provider and medical coder education. Medicare did a study using 2017 data about Z code utilization among Medicare fee-for-service beneficiaries. And what they found that as among those 33.7 million fee-for-service beneficiaries in 2017, only 1.4% of them had claims with Z codes associated with them. The 5 most utilized Z codes were homelessness, problems related to living alone, disappearance and death of a family member, other specified problems related to psychosocial circumstances, and lastly, problems in relationship with a spouse or partner. It was also found that among those claims that did have Z codes attached to them, the majority, 76% of those beneficiaries were white. So they're not capturing a majority of the population when they're reporting the Z codes, or even the Medicare population in general. Now, why is the utilization of these codes so low? And that some of this goes back to the challenges I had mentioned earlier. Just a general lack of awareness regarding the codes, difficulty in determining when and how to report the codes, a lack of internal processes to incorporate Z codes into the workflow, confusion as to who can or should document social determinants of health, and then lastly, lack of explicit financial incentives for their use. Let's take a look at care delivery. Addressing social determinants of health and health equity is part of many equality initiative programs, and a great example of this is the ASCO COA Oncology Medical Home, which focuses on patient-centered care. And part of that patient-centered care is equitable and team-based care, which means that patients are provided navigation for support services and community resources that are specific to their needs and preferences, psychosocial distress screening is performed, referral for provision of psychosocial care is provided as needed, and that support services can be delivered either on-site or through an off-site collaboration. For those who are familiar with or who have signed up for the enhanced oncology model, E&M participants will be required to establish and develop a health equity plan, collect beneficiary level socio-demographic data and report that data to CMS, using the health-related social needs screening tools to collect HRSN data, provide patient navigation to E&M beneficiaries, such as connecting them to services and community resources, and lastly, providing E&M beneficiaries with 24/7 access to a clinician that has real-time access to the patient's medical record. There are also other quality programs out there that are addressing social determinants of health, such as the National Comprehensive Cancer Control Program, the Accountable Health Communities Model, and Healthy People 2030. And what you'll notice about these programs is they have many similar attributes, such as promoting equitable access and addressing health-related social needs, but also training their workforces to address these patients in need. Now, implementing, addressing social determinants of health in practice can also certainly be challenging because there's just not this one size fits all solution. And I really like this quote from Dr. Tucker Seeley. This was a JCO Oncology practice article. And Dr. Tucker Seeley is also the chair of our Social Determinants of Health Task Force. And what he said was that unique factors that vulnerable populations experience because of social and historical discrimination across multiple levels, both at an individual and healthcare system levels, must be considered. So it has to be tailored to the population of your patients and their needs. So how do you connect those Z codes with social determinants of health? And CMS has really had a focus on health equity and social determinants of health over these last few years. They have this great resource that is called Using Z Codes, the Social Determinants of Health Data Journey to Better Outcomes. And they broke this process into 5 steps. The first step is actually collecting that data. And that data can be collected through health risk assessments, screening tools, person-to-provider interaction, or even patient self-reporting. Then the information has to be documented. That document should be documented in the patient's paper or electronic health record. But it's important that multiple providers or whoever is collaborating in the patient's care also has access to that information. Then that information must be mapped to the appropriate Z codes. And you would select the Z code that corresponds to social determinants of health. And we'll review later in the presentation as to how to do that. Step 4 is analyzing those Z code data findings. That data analysis can be added to key reports and also shared with social service organizations, providers, and health plans. Lastly, once you have connected the Z codes, done the data analysis, you can look at that information and identify unmet patient needs. And a disparities impact statement could be used to discover opportunities for advancing health equity. And CMS also developed this template disparities impact statement that I thought was pretty helpful. So using this template, you can use the social determinants of health and Z code data to identify health disparities, priority populations and needs, to define what your goals and targets are, to establish a health equity strategy, and also to monitor and evaluate progress. Now, addressing social determinants of health is not this, like A to B process. It's always going to be a continuous process. Your populations might change. You you might address some issues and then you find that you have to address others. So you're always going to be addressing and identifying those patients with social determinants of health, connecting them with Z codes, link the practice processes to social determinants of health to the appropriate CPT codes, and then also continuously evaluating progress and goals. And it does seem like an overwhelming process to address these social determinants of health, because there are some things that are just not as easily remedied as others. And again, each population is unique. Sometimes it's best to start with just a small part of the population. After you identify, well, what are our top issues and what are our patients' top needs? You can go through the process and almost do like a pilot. So then in the future, you can look to that and say, okay, what did we do well? What did we need to do better? And then apply it to other situations. Now let's take a look at the Z codes themselves. There are about, right now, 10 categories of Z codes, and these are located in Chapter 21 of the ICD-10 Manual, Factors Influencing Health Status and Contact with Health Services. And the categories range in topics from problems related to education and literacy, to housing and economic circumstances, social environments, the patient support group, and just general psychosocial circumstances. But what does this actually mean within the categories? This is just a high-level category. There are codes underneath it. So here is a perfect example of kind of the simultaneous lack of and multiplicity of codes. And I specifically chose this one. This is Z59, problems related to housing and economic circumstances. And what I did here is, in these colors, I kind of grouped like descriptions together. So as you can see here, there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, about 12 categories or 12 codes related to housing or housing instability. There's 3 codes related to food inadequacy or insecurity, 4 codes related to income issues. And then there's this one kind of nebulous code related to insufficient social insurance and welfare support. And usually that code is used to describe patients who don't have insurance, but it's not extremely obvious, I think, to anyone. But what else does it describe? Does it describe the population of patients that are kind of underinsured? Maybe they have an insurance plan, it's just not very good, it doesn't cover it or not. Are they stuck in that, that limbo where they don't quite qualify for a program like Medicaid, but they really do need the financial assistance? So, they're working very hard on trying to come up with codes to describe certain situations, but in other areas, you can see where the category has exploded a bit. It can make it a little bit difficult to find the appropriate code. In terms of reporting guidelines, this section of codes identifies issues related to a patient's socioeconomic situation. They're not procedural in nature. So therefore, they always must be accompanied by a procedure code, such as a CPT code, a HCPC code, or an ICD-10 PCS code. In addition, the Z code does not have to be the primary or first listed diagnosis, or in other words, the primary reason for the visit. This is also a big point of confusion, understandably. Who can document the social determinants of health and the Z codes themselves? Well, besides the physician and clinical staff, it can also be reported by patient's case manager, a social worker, the discharge planner, as I mentioned before, clinical staff, but it can also be reported by the patient with a self-reporting or screening tool. An example of this is the NCCN distress thermometer. So you can see here, and I pointed this out with arrows, there are these 2 categories that are related to social determinants of health: social concerns, practical concerns, and then there's a space to list other concerns as well. So what would a patient do in this case? So for example, the patient can indicate on the distress thermometer that they are experiencing significant stress regarding their medical expenses because they don't have medical insurance. And also they have problems covering their rent because they are currently unemployed. So they have checked off these concerns in the distress thermometer. So then you go to the chapter in the ICD-10 manual and identify the appropriate Z codes under that category, Z55 to Z65. So in this case, it would fall under the headings of Z59, problems related to housing and economic circumstances, and Z56, problems related to employment and unemployment. And underneath those categories, you would select the codes that most accurately describe the patient's indicated social determinants of health. So on the distress thermometer, they checked off their practical concerns were housing, insurance, and work. So therefore, the ICD-10 CMZ codes that most closely are attributed to those items are Z59.81, housing instability house, Z59.7, insufficient social insurance and welfare support, and Z56.0, unemployment unspecified. It's always important to remember to code to the highest level of specificity, to include other relevant diagnoses in the claim and medical record. And remember that the Z code must always be accompanied by either a HCPC, CPT, or ICD-10 PCS code. Now, how do you connect the Z code to a CPT code and therefore get credit for your work and therefore get credit for reimbursement for the services that one is providing? Well, there are certain CPT codes for addressing social determinants of health, and those are evaluation and management services, prolonged evaluation and management services, care management services such as chronic care management, complex chronic care, and principal care management, and also transitional care management services. Now, what do those services look like? I'm sure you are all familiar with evaluation and management services. That involves the evaluation, assessment, and management of either a new patient or an established patient on a single date of service. And there have been many changes to the E&M services since 2021. Those services are now selected based on time and medical decision-making. In terms of medical decision-making, that Z code can be used to justify and also support medical decision-making and medical necessity, because it could represent a moderate risk of morbidity from additional diagnostic testing or treatment. Diagnosis or treatment can be significantly limited by social determinants of health. For instance, if the patient is not able to keep up with the appointments or afford their drugs, or doesn't have a place to stay. The other option to select an E&M code is time. And time now includes both face-to-face and non-face-to-face activities, which can account for work associated with addressing social determinants of health, such as obtaining or reviewing their separately obtained history, counseling and educating the patient family caregiver, referring and communicating with other healthcare professionals, and also care coordination. Now, okay. In terms of prolonged E&M services, this accounts for additional time for evaluating, assessing, and managing a new or established patient on a single date of service. So it accounts a time in addition to a primary E&M service, also includes face-to-face and non-face-to-face activities. And that Z code could be used to support that additional time needed working with patients who have a social determinant of health. Care management services are not very well utilized by oncology, or just throughout medical specialties. A lot of times it's used by primary care physicians, but hasn't quite taken off the way I think Medicare has wanted it to. But care management services are management and support services for patients with either a single high-risk condition or multiple conditions over a calendar month. And addressing the patient's social determinants of health could be part of the required care plan, in addition to work performed by the physician, qualified healthcare professional, or clinical staff. It includes communication and coordination with home and community-based clinical service providers, and accounts for non-face-to-face communication with the patient, family, or caregiver. Transitional care management services involve the management of patients discharged or transition from a hospital or facility setting to their home and community setting over a period of 29 days. And a Z code indicates whether a patient may require attention to psychosocial needs and activities of daily living support. These services include both face-to-face and non-face-to-face activities. And these activities may consist of coordination of care with community services agencies, follow-ups, and referrals. Patients with social determinants of health, when they're transitioned or discharged from a hospital, this is sometimes when they're at their most vulnerable. What if they're discharged and they don't have any place to go? What if they don't have any support at home or someone to help take care of them? So obviously there is going to be a little bit more work with those patients involved than maybe with than some others. So just to have like a short comparison table here, the differences between these types of services. E&M services can be reported based on time and medical decision making, while those care management services and transitional care management services are time-based codes. Now, the difference between these care management services, transitional care management services, versus E&M services is that E&M services are date of service activities only. So you can only count the time or that's involved in that specific date of service. Whereas care management services and transitional care management services are over a longer time period. But all of them include both face-to-face and non-face-to-face activities. However, care management and transitional care management, and this is one of the tricky parts of these services, they can only be reported by one provider per beneficiary. In the case of care management services, that's per calendar month. In the case of transitional care management services, that's during that period of 29 days. I always tell people for full code descriptions and guidelines, refer to the AMA CPT Professional Edition 2023 that has now been published. But I also want to draw your attention to some ASCO resources. The first one is ASCO's Health Equity website, where ASCO has developed a wide range of resources that includes things like podcasts and other resources and statements to help the cancer community understand and address health equity issues in cancer research and care. We have an amazing coding and reimbursement page on ASCO Practice Central. And right after this, I'm going to put the link to that in our chat. We now have a care management services, practice administration, and reimbursement guide, along with many other resources. And this resource provides information about how to code, how to report, and the ins and outs about sort of the care delivery and how to implement this in your practice. We have the oncology model fact sheet on our Medicare program page for those who are interested in learning more about their program. And I've also included links to the other quality initiatives that we discussed, as well as the distress management thermometer and those other quality initiatives that I mentioned earlier. I am just going to post the link to ASCO Practice Central here, but I will open it up for questions. And any other questions, whether it be regarding social determinants of health or any other billing and coding questions, can be sent to ASCO staff at practice@asco.org.
Thank you so much for that information. So if anybody has a question, feel free to unmute your line or type it into the chat.
So I'm pasting links to ASCO Practice Central here. So please take a look at these websites. I'm gonna bring this over here. I'm gonna share my screen. We have a lot of great resources. I'm sorry, it's the coding and reimbursement page. Okay, we always include a tip of the month to talk about hot topics or just general coding and reimbursement tips. Any important updates regarding the 2023 E&M changes, coding and reimbursement updates, and the resources that I was discussing before, care management services. Oh, we also have a resource on, of course, coding and reporting on social determinants of health, advanced care planning, and split shared E&M services. So be sure to go to the page and check that out.
All right, so I don't see any questions coming through, but thank you so much for presenting that information. We appreciate it. And if we have any follow-up questions, I'll certainly route them to you.
Yes, definitely. And again, practice@asco.org. I'll put that in here in case you have any questions. And you can certainly email me and we will get back to you in a very timely manner.
Wonderful. Thank you. So thank you all for staying online. We know this was a long webinar. We appreciate you staying to listen to the information. We appreciate the presenters and our sponsors. This concludes our webinar for today. So enjoy the rest of your day. Bye-bye.